Hi everyone, good morning. My name is Shalika, and along with me, Lauren and Andrea will be presenting as well. So this presentation will take a population health approach with strong focus on social determinants of health and how it impacts planning and service delivery. So Deb and Mike has already set the platform for social determinants of health, so it makes it easier for me to explain it. And I will be covering the social determinants perspective, and Andrea and Lauren will give you a practical example of population profiling of dental disease. And I will be also going through one or two models. So from a clinician's perspective, it would be very foreign or new to you, but I'll try to explain it from your perspective. And as we are moving towards the social determinants of health, it is very important for clinicians also to understand the implications of social determinants of health. Now, to begin with, just to set the context of the presentation, tooth decay is the most prevalent health problem in Australia, and it is 5 times more prevalent than asthma. And more than 25% of the adults have untreated tooth decay. Dental diseases comprises the highest cause of acute preventable hospital admissions, and more than 40,000 Australians are hospitalized for preventable dental conditions every year. And more than 26,000, a very significant proportion of children under 15 years are admitted for preventable dental conditions. And also, significant number of Australians die as a result of oral cancer. More than 650 people die as a result of oral cancer, which is very significant. And following on from the extent of the problem, this is how much it costs to treat the problems. You can see that oral diseases are the second most expensive disease group, just next to cardiovascular disease. And it is more expensive to treat than all the cancers combined. And direct annual expenditure on dental treatment during 2008 and 2009 was 6.7 million nationally, and about 1.9 billion in Victoria alone. So you can see that it has significant impact on our budget. So given the extent of the problem and also the cost associated to treat the problem, we all know that dental disease are emerging as a significant public problem. And the figure here shows a wide-ranging impact of dental diseases on society, individuals, and the communities, and also the healthcare systems. So it's not just the individuals who are affected by the determinants, it's also the healthcare system and the communities in terms of service delivery, healthcare expenses, treatment provisions, waiting lists, demand management, etc. And some of these diseases come out or emerge as a result of factors that are beyond the control of individuals. And these are called as social determinants of health. They're very, very closely linked with the health outcome in the community. So you can see that these social determinants are the conditions in which people are born, grow, live, develop, work, and also age. So this is the social spectrum of a life, and this dictates how we live in the community. And these social determinants are influenced by the broader, you can see it's a spectrum, it's a social spectrum. You can see there are different areas which can impact on the health outcome. For example, political, environmental, work conditions, and also health behavior. All these are impacted by the distribution of power, money, and resources in the community. And social determinants have a very strong influence on health inequalities and inequities, meaning the longer people stay in disadvantaged circumstances, the more likely they are to have poor oral health outcome and unable to reach their fullest health potential. So the most disadvantaged groups always have the highest risk exposure in the community, health damaging risk exposure. Now take for example from your perspective, from a clinician's perspective, you will be seeing so many patients coming from different circumstances. You might treat them, educate them, and then send them back. And you'll be surprised to see them back again with so many different problems, more problems. And you would say that they wouldn't have followed your instructions at all. And this is because you must understand that the people who are sitting on your dental chair come from a range of social and environmental conditions, living and working conditions. And it is very important to recognize that it is if knowledge and education is of little value, if resources are not available to change the behavior in the society. So it's very important to make sure, to understand that it's the broader context in which people live that impacts on their health outcome. So we have to move beyond the treat, drill and fill mentality and also look beyond, outside the mouth, not just inside the mouth. And also, it's not just about focusing on the individual patients, so we have to collaborate with other partners, for example, non-health sectors, to make sure that we work in collaboration, in partnership, and direct our actions to the entire community and not just the individuals. And applying the same determinants, I'm not going to explain this again, it's the same determinants. This is very specific to child oral health, and this is called as the Fisher-Owens model. And you can see that there is a time component as well. So children's lifestyles are very dynamic and are very unique, and they have different lifestyle and trajectories that can impact on the outcome of the oral health disease. So simple models which are individually based is no more adequate and not efficient. Children live in families, and families are embedded in the communities, and communities are influenced by social determinants of health. So it's a very, very strong concept, and there is strong evidence to show the impact of social determinants on health. And in view of how the determinants impact the oral and the general health, this is the common risk approach where we integrate both oral health and general health. We know that both of these diseases share common risk factors. So the common risk factor provides valuable opportunity to integrate oral health promotion with general health promotion. And such targeted programs are always more effective than treating just single diseases. So this is going to be a very, very consolidated and strong approach to treating oral disease along with general health outcome as well. Now, these are the communities which often experience marked disadvantage in terms of oral health outcomes, and also evidence has shown that these communities emerge from a very disadvantaged position. For example, people from low socioeconomic status, dependent, elderly people, indigenous people, people residing in geographically isolated areas, some migrant groups from culturally and linguistically diverse communities. So these people have highest disadvantage and also poor health outcome. So we have seen how communities, disease emerges in communities. So we must also understand that we have to come together in a collective way to address these diseases in the community. And one of the process of doing this is through health promotion. So health promotion is a process of enabling people to take control of their own health, precisely to take control of the determinants that impact their health outcome. So Deb has beautifully explained the 5 action areas of Ottawa Charter, and you can see here on the right-hand side the logo. Every framework, every logo says something. It's not just there, it has a beautiful meaning to it. Now you can see that there is a big round circle there, and inside that circle you have a smaller circle, and then you have 3 wings originating from that small circle. So the outer circle shows that building healthy public policy, so it encapsulates everything. It means that the policy should be strong to contain everything. If you have healthy public policy, you have healthy communities. And the larger wing there, it's breaking the policy circle. So there's a reason for it. The individuals, communities, and society are always changing. So it means that it is symbolic that the policy should adapt to the changing needs of the communities. So you can see that the logo means a lot in terms of collective approach and meeting the needs of the people. Now, effective health promotion approaches involve populations as a whole, not just targeting specific individuals who are at risk. And is always complemented by targeted activities, not just health sectors, but beyond the health sector. So you collaborate, partner with health promotion, you collaborate with public health, medical people, dental people, so agriculture, everything, policies. So you collaborate with different sectors there. And also the action is directed on the determinants, and which are the causes of the diseases in the communities. And it combines diverse and also complementary methods and approaches. And also it aims at concrete public participation and engagement. Now, we all know that oral diseases are largely preventable, and although advances in curative and dental care has helped us, it is not just treatment alone. Treatment alone cannot eliminate teeth disease. So it's very important that we look beyond the mouth and make sure that we collaborate with different sectors to have an integrated approach. So you can see that the downstream approach there is called as the individual approach, what you do in the clinical sector. So it is very biomedical focus, and you're focusing on one particular individual. So moving from there to midstream, where you have lifestyle behavioral factors of focusing on the community, to socio-ecological approach, to policies and programs. So we have to move from downstream intervention, midstream intervention to upstream intervention. So it is like a continuum to have all these integrated in some of the programs and policies. And such approach makes a valuable contribution to all the programs, and health promotion programs should be multi-component and also integrated and multi-level, and should complement each other. So that is what it says there. And having said that, what we now have is a very compartmentalized approach. Mouth is always separated from the rest of the body. It is seen as separate, even with the health promotion, oral health and general health activities. We see mouth as different to general health. So we need to make sure we adopt a common risk factor, and oral health promotions are often developed in isolation. So silo interventions are no more useful. So you need to have an integrated approach to health promotion and practice. And often it does not involve community engagement and participation, and not informed by evidence-based public health practice and policies. So that is my part of the presentation. Lauren will take you through the population required.
Okay, so just tacking on to some of the themes that Deb and Mike and Shalika have spoken about this morning, how do we apply this in a practical way? And I'm just going to go over some of the research that we've been doing in our unit at DHSV. And I'd like to just acknowledge Ridwan Maguire, who's no longer with our unit, but she primarily worked on this while she was working in our unit. So, profiling the population distribution of dental disease. Why do we do it? It's different from an individual risk assessment in that it takes into account risk at a community level. It's solution and equity focused, so we don't want to create a bigger gap between those that are already disadvantaged. It can be helpful for population monitoring and evaluation, so you can see changes over time and the influence of interventions that have been put in place. It's multidimensional. It doesn't just focus on whether or not a person has a healthcare card or their oral hygiene status. And it focuses on functional needs versus normative needs, so what people need to function in their life rather than a blanketed norm that's been put on them. So why do we take this approach? So we're trying to work out not just what the size of the problem is, but what it's related to and identify possible solutions. So, for example, what is the balance across the community for particular population groups? Is it different for children and different for adults? How do they relate to each other? And what can be done at a population, regional, community or setting level? So to start this work, we adapted the WHO framework for oral disease surveillance, and you can see that we've split it into 6 broad determinants and 2 outcomes, and we actually haven't been able to find a lot of information on quality of life outcomes, so we've focused mainly on the disease outcomes. So our determinants were policy, which included services, programs, the workforce and eligible populations. Systems and services, so delivery models and the type of personnel. The use of services, so reason for attending a dental clinic, early detection, the care that was received. Socio-cultural factors, including SES, education, ethnicity. Environmental factors, so location, whether people were rural, regional or metro, the fluoride status in their area, and also behaviours, so oral hygiene, their diets, alcohol and tobacco use, and the use of fluoro. And then our outcome measures, primarily under the disease component, were the number of teeth present, the experience of bleeding gums, and the main one that we focused on was DMFT. So there were 4 underpinning frameworks in the work that we did. So the WHO model that I just showed, and then the models that Shalika has previously spoken about, so the Fisher-Owens model, and the socio-ecological model of health, and the social determinants of health. And these helped us to determine our profiling domains. So our approach for indicator selection, our indicators needed to be relevant, they needed to be applicable across population groups, they needed to be technically sound, feasible to collect and report, so the information had to be out there for us to be able to use it, and if it wasn't available, it gave us a chance to advocate for it to be collected. They had to be action-oriented, so we didn't really want to be measuring things that couldn't be changed. And they had to have currency and utility, so the information had to be updated regularly. There was no point using information or data that was 20 years old. So some examples of the indicators for each of our domains. Under policy we had local government policies, so whether or not local government areas had policies that addressed oral health risk factors. Under health system and oral services we had emergency care, for example, so the ratio of public emergency oral care to public general oral care, waiting periods, so we looked at the waiting lists in each area. Under socioeconomic status, we had, for example, education level, ethnicity and cultural group, healthcare card holders, environmental risk factors, whether or not the water supply was fluoridated, as I mentioned before, the geographic location, and the use of oral health services, so whether or not children were going under GAs, and whether or not the treatment that was being given was about early detection or if it was preventive care compared to far down the line restorative care, and different risk behaviours, so alcohol consumption and tobacco use. And these are just some of the data sources that were used to put into the model. So a lot of the information around the socioeconomic data came from the ABS, so the most up-to-date census information. Our primary outcome source was the titanium data set from DHSV, so this focuses just on public dental. We don't have any information on the private sector. So whether or not areas had Smiles for Miles in them, the fluoridation status, which was from the Department of Health, and also a number of different population health surveys. And now I'll pass you on to Andrea, who's going to take you through the analysis that was done.
Thanks, Lauren. I wasn't sure I was going to get here today, which is why I was surprised, not listed anywhere and not having a name badge, but I am here. So I will also take the opportunity, I'm going to talk to you about the analysis and the data, and Lauren's just listed the data sources, and if I can also put in a plug for collecting all the data you possibly can, because we do rely heavily on titanium and do look at the quality and the integrity of the data and use it in as many ways as we possibly can. And what you'll see I'm going to present in the analysis is actually relying heavily on the DMFT data and also the treatment codes and even the workforce data, who is doing the work with the clients that come in. That's all of critical importance to us to be able to do research like I'm going to show you here, and then apply that to planning and processes of the organisation. Now, is there a... Okay. So as Lauren's described, we went through a concerted effort to review all kinds of models and parameters of how should we put this data together, what's the most useful way. Then we had to go through and look, well, what data is available? One of our underpinning priorities is also to use publicly available data. It's already funded, it's available, it's often underutilised, so to assess the quality of it and to use it in as many ways possible. Then we want to make sure that the data is behaving as we'd expect it to. So what we did is do a whole series of confirmation analysis to really confirm, are we seeing the expected relationships in the data we have, so that we have confidence that what we've got is representative of the general population, or the general dental public population, and is similar to what you would expect to see, knowing what the evidence tells us. So we also have to be on top of the research evidence that's emerging in the literature. So what we did see is, as you'd expect, so that increasing disease, so DMFT, I think this should probably all be in lowercase DMFT, because I think this is child dental, possibly, with CEFA. So CEFA come from the census data, where we had postcode level, area level, socioeconomic status applied to, so it's not individual level, it's area level. One of the other things we had to do with the data is assess where the data source. So it's a whole series of looking at what data is available. Sometimes we had to disaggregate it from a local government area down to a postcode level. Sometimes we had to aggregate it up from postcode level up to local government area. So there's a lot of work which underpinned what Lauren went through quite quickly. But we did see the expected relationships and gradients between DMFT and socioeconomic status in that top figure. We also saw about 50% difference in DMFT between fluoridated and non-fluoridated areas. And we also saw a relationship between DMFT and remoteness. So we were quite confident that we were seeing the types of relationships we would expect with the data, even though we know this was only public dental data. We also went through a series of, so Lauren looked at all the, explained all the types of indicators that we put, but it's important to know how the relationships between those variables. So what we did was to do, again, exploratory correlation analysis to look at how interrelated are these causes. So if you only look at one, for example, the healthcare card. So we use healthcare card for eligibility status. But really what we could see in the data is healthcare card is quite highly correlated with remoteness, with smoking status. In communities where there's high proportions of healthcare cards, those communities also have high proportions of GA rates and public housing rates. So healthcare card is one indicator that's often used, but all of those things are highly associated with it. So if someone walks, because the question is, why does having a healthcare card in my wallet impact my teeth? In what way? What's the pathway? What's going on? Because obviously it's sitting in my wallet. Why would it affect my teeth? So we try to explore those relationships. We also see that something like distance to public clinic is related to ethnicity, migration, the proportion of people coming in for non-early treatment, public housing. So again, all these things are related, and we're trying to understand these relationships so we can better serve the people that in the community. And again, the last one, if we look at remoteness, so we might do planning based on how far people are for a dental clinic or where they live geographically based. But again, you can see that proportion with high alcohol, smoking, lower education, lower income are all tightly associated with remoteness. So it's a proxy measure for all those other things, all those social determinants of health, all those other factors that are influencing people's lives. So we also did some factor analysis. So this is to show to everybody here and to Deb, of course, and we do a lot of work with this data where we find we don't just harp on about getting the data and then don't do anything with it. But so we do, when we put all these things in a model, you can't analyse 50 or 100 different indicators, so you've got to do a process of data reduction. So we try to do factor analysis to see how do these variables hang together so that you can come up with a factor, a measure that's pulling together the relationships between these variables. And we saw, if we look at child oral health, we see that GA rate is one of the strongest correlates with child oral health at a community level. Then factor 2, we get the ones in red are kind of where they hang together in each factor. So distance, remoteness, environmental factors such as fluoridation. So geographic and environmental factors are tightly associated and impacting on child oral health. Factor 3 we've got is a factor that comes around migration and ethnicity and eligibility. And the fourth factor is some general socioeconomic indicators, smoking, eligible population. And these are all proportions at a community level. So this is moving from individual associations to even at a community level, these things are highly correlated. So we then went through it. So Deb, of course, would say to me, why is this of any use to me at all? How can I apply this for the organisation? So we went through this, testing the use of this concept and these models and this data. Now it's cut off the top, but it's for service planning. Why is this of any use? And really it's about moving to a process of identifying community need and allocating resources. I'm going to go through a series of where the example is to allocate funding, but then it's about taking that funding and using it in the right way to address the need. It's not just about the funding. So through the series of analysis and testing, we came to use 6 variables to come up with some population profiles that we could apply across the state. Some of this was informed by data, so that we had statewide spread of data and had high confidence in the data that we were putting into the model. So the variables that go into the model, which I'm going to show you, were distance. So these are all standardised and normalised so that they could be used across the state. So the standardised distance to the closest public dental clinic, the eligible population, and Martin and the team in the data area and health intelligence unit within the organisation have done a lot of work to try to understand what is the eligible population, what's the denominator we can use there, and so we were able to use their intelligence and use that into our modelling. The proportion of people in the community who speak a language other than English at home, and that came from census data, the fluoridation status at a postcode level, remoteness at a postcode level, and CIFA as an all-encompassing SES variable. So then we summed those standardised variables after they've been normalised and standardised, and used that to provide a measure of risk. So this is community postcode level risk for poor oral health, with a higher number being higher need. What you probably can't see there is that some of those numbers, if you look at the legend on the right-hand side, it goes, red is higher need, so higher number, higher need, and it goes to almost a white. And what you see is that some of those numbers are negative. And in fact, when you look at some of the things that we've looked at, some of the communities actually have protection. So you've got not only do some of the communities have high needs, but actually some of them have more factors that you would consider being protected from the negative aspects that we were trying to model. So you can see this is not of any note in terms of noting down any specific areas, but there is a gradient. In metropolitan Melbourne, there's a gradient so clearly it's not just about fluoride, because fluoride is pretty standard across there, and also across Victoria. So there is a gradient. There are areas with high need, there are areas that have potentially have some protection at the community level. And don't forget, this is all relative. So it's relative to another area. They are more protected or at higher need than other areas at a postcode level. So this is about us trying to take a population health approach, social determinants of health, using existing data, high-level quality research, using indicators that we have confidence in, bringing them together to try to model the risk that a community, an individual, a family within the community might face just by residing in a particular area. Then we try to use this in different ways. So we've now applied this with, if you add a Medicare local boundary on, trying to work with Medicare locals to inform their decision making and their planning about resource allocation as well. And some areas, they are very large areas, of course, so there is heterogeneity within the areas, but some areas have significant oral health risk. So then we try to take the numbers, so we get a population need number, an index, because while graphs are pretty, we love numbers. So we take the numbers and try to look at, okay, so if we say people, if we were going to use something like this to allocate money, obviously those people that had some protection would get negative value, so we had to rebase things so that a distribution would still be equitable. We looked at eligible population, so that if you apply something on a per capita basis, how could that be applied, and then to model some particular number. So this is not of any meaning, these are just scenarios. And at this point, this is when I hand these models over to Tim and in the finance area and say, this is a public health approach using needs, a holistic approach, social determinants of health, to allocate funding, to think about resources and service planning. And it's not to say that money should go to a particular agency or particular service that's already there, but this is about distributing against need. So the implications are, as I've just said, that we can take into account a range of influences, the community and individual, and both on oral and general health status, because we don't want to just improve oral health, actually. We want to improve general health and oral health along the way, and people's quality of life and their social circumstances. So that's why some of the things that we've measured and put in the models may appear unrelated to oral health, but we're looking at a more holistic and multidimensional view of the factors to consider. And I think when Deb says what's our vision and what are our big ideas, it really is about trying to connect, for a piece of work like this, how can we connect people with the right services and strategies at the right time in their life course and delivered in the right way, ultimately with the aim to reduce inequity and disparities in the burden of disease at a population level. And then I think just to these are some of the core members of our team. I think you will have heard the passion and the commitment in the other members of my team who spoke earlier. And we're very fortunate to be located in such an organisation who embraces the approach that we bring. So thank you very much.